To assess the lateral elbow using ultrasound, we first of all place the proximal end of the probe onto the lateral epicondyle, and you can see the bone there. You can also see the radial head. It's important to assess for any fluid coming out of the radial head. Now, often we will see this view, but it's important to understand that most issues when it comes to tennis elbow actually involve the ECRB tendon specifically. When we do this view here, there's 3 layers that we need to be aware of. The first layer at the top is the extensor digitorum tendon layer. Underneath that we have the EDM, so extensor digiti minimi and extensor carpi radialis brevis, and then underneath that we have the radial collateral ligament that joins up with the annular ligament that sits on top of the radial head. Now we want to assess the ECRB specifically, and to do that what we actually do is we slide the probe up and we angle back down, and what we can see here is specifically the fibers of ECRB attaching there onto the bone. And this is where we need to look carefully for any tendinopathic change, any neovascularisation and any tears. Now, if we move slightly more inferiorly, so underneath the radial head, that's when we can actually pick up a better image. You can see the fibrillar alignment there of the radial collateral ligament, which, as we said, is continuous with the annular ligament. Now, if we spin into transverse section, it's nice to be able to orientate ourselves around the cross section of the muscles. So first of all, you can see the radius, and you can see the posterior interosseous nerve running through the deep and superficial heads of supinator. Now, if we move slightly superiorly, this is the muscle belly of ECRB, which is continuous with the muscle belly of ECRL, which, remember, doesn't attach onto the lateral epicondyle. Now, this is a structure that we need to get familiar with. Now, we call this the scorpion's tail, which is a nice soft tissue landmark, and that's actually specifically the tendon of ECRB, and that sits a little bit like semimembranosus in the hamstring, and that sits underneath extensor digitorum. Now, if we move more inferiorly, we can see extensor carpi ulnaris, which sits next to extensor digitorum, and just be aware that as we move more distally, we will see extensor digiti minimi in between those 2 muscle bellies. So if we move back up, that's extensor digitorum. And then, as I mentioned, this is the area we really want to follow all the way back up to the lateral epicondyle. So we can follow it, trying to tilt the probe past the radial head, and you can see the annular ligament there, the long fibers of the annular ligament. And then as we come up, we can then see specifically that attachment onto the lateral epicondyle. And that really is where we need to look for any tendinopathic change or any tears, and also where we need to assess on power Doppler for any neovascularisation. And that is specifically the ECRB tendon attachment onto the lateral epicondyle. And actually, this transverse view can be very, very helpful, and is also a nice view to use if you're going to do any interventional procedures, such as PRP or dry needling, because you can really target that specific tendon. To assess the posterior elbow with ultrasound, again with the patient with the elbow at 90 degrees, gives us a nice visualization of the joint. Now, if we pop one end of the probe onto the olecranon, and then what we can do is line up the fibers by fishtailing the probe to see the fibers of the triceps, and you can see there the musculotendinous junction of triceps. Now, it's important to ensure that you're fully aware of where the joint is, and this is often something that we find people get slightly wrong. You can see the olecranon fossa on the left-hand side of the screen. Now, that is the posterior fat pad, and that's where the olecranon moves into the fossa with full extension. But that isn't where the joint is. Now, you can see some fluid underneath the posterior fat pad, but it's tracking from the joint, and we know where the joint is because there's articular cartilage. We can also move the joint to see if there's any fluid that comes out, but also to get an appreciation of how the joint moves and to look for any osteophytes. We can also move the probe into transverse, and you can see the triceps tendon in the middle of the triceps muscle belly. If we move it, keeping it in the middle towards the elbow, then you can see the olecranon fossa in transverse section. And as we move further towards the olecranon, you can see the articular cartilage of the bone. Look for any fluid around the area. And you can then obviously follow it down into the olecranon, following those triceps on the superior aspect of the image where it attaches in to the olecranon. If you're assessing for a bursa, it's very important to use very light pressure, and you can even use standoff. So as we come up over the top of the triceps, now it's the tissue above the triceps that is where the potential space for the bursa is, and it's just a little bit of compression there to see if there's any extra fluid. It's always very important to put your power Doppler or color Doppler on to see if there's any inflammation in that, because one of the main reasons for an olecranon bursitis is an infection, and that's something that we don't want to miss. To assess the medial elbow, if we palpate the medial epicondyle, all we need to do is put one side of the probe onto the medial epicondyle. Now, a nice little tip to remember is that if you point this end of the probe towards the little finger, we should see a nice image of the ulnar collateral ligament. You can also see the joint underneath the ligament, and we can do a valgus stress test to assess it in a dynamic stability. So as we apply some valgus stress, there should be very, very minimal opening up of that joint, as we can see here. If we then move this side of the probe up towards the thumb, so we need to fishtail the probe, keeping this end of the probe still, then we can see the common flexor tendon coming through the middle of the muscle belly and attaching. It's got a very short tendon attachment, unlike the common extensor tendon, onto the medial epicondyle, and you can see the intramuscular tendon of the common flexor tendon and the musculature there. To assess the ulnar nerve, the most simplest way of doing it is to find the medial epicondyle again and the olecranon and put the probe across the two. And what you can see on the left-hand side is the epicondyle with the ligament over the top, and you can also see the ulnar nerve. On the right-hand side, you can see the olecranon and the joint. To assess the ulnar nerve, we can do this dynamically. We can just move the elbow, and it's best for the operator to move the patient, and you can just move them into flexion and extension. Particularly as you move them into flexion, sometimes that nerve will ride up on what we would call the mountain, which is the medial epicondyle, and it's really important to ensure that medial epicondyle doesn't move to fully assess whether the nerve subluxes over the bone. You can also follow the nerve further up, so you can see the nerve next to triceps there, but also as we go into the groove and out the other side, we can see that the ulnar nerve actually sits nicely in the two heads of flexor carpi ulnaris.
Okay, we're going to show you a few ways of assessing the distal biceps tendon. We start with the anterior approach and then we do the medial approach. The anterior approach, you can start with the musculotendinous junction. If you go distally, you can see the tendon forming under the superficial fascia, short head and the long head. And if you continue to go distally in a cross section, you should be able to follow this slowly all the way through. And then we reach the bone's attachment coming up. There's the footprint onto the bone. This is quite challenging, especially if you have a lower end machine, and longitudinal in this plane, in this approach is also quite challenging. So a good alternative is doing the medial approach. So for that, we put the arm in 90 degrees flexion. We line it up longitudinal with the medial condyle. Then we go straight forward into the forearm. And our eye should go to the radius, which is the cross-section bone there with the articular cartilage on top, on the bottom of the screen. And then we continue to go forwards, 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 until it starts to line up. There's the tendon. It usually sits below, deeper to the artery. So here's the tendon and it hits the bone, the radius. Now, if you rotate slowly in pro and supination, you can follow that movement, come back to where you came from. And that's a nice way to longitudinal assess the distal biceps tendon from the medial side. You can always then do a transverse approach by spinning on it. And that's it. So that's the medial approach. We normally prefer that to the anterior approach. It's more consistent, easier to access.
Did you find that video useful? If you did, don't worry, we've got loads more videos for you. You can like our videos, you can make a comment, you can subscribe to our channel to get all of our new videos, and you can even join our membership. Good luck scanning.